Today we are going to discuss about diagnosis and treatment of hemochromatosis. Diagnosis and treatment. So first we'll discuss about diagnosis. How do you diagnose this patient coming with the symptoms which are relating to hemochromatosis? First, in diagnosis we have to assess the degree of increase in body iron stores. How do you measure this body iron stores? You have to measure serum iron levels. And this serum iron level should be around 50 to 150 micrograms per deciliter. Next, percentage saturation of transferrin. It should be in the range of 20 to 46%. Third one, you have to measure serum ferritin concentration. It should be around in the range of 20 to 250 micrograms per deciliter in men, and it should be in the range of 15 to 150 micrograms per deciliter in women. Next, fourth, you have to do liver biopsy. In this liver biopsy is very important. Why? You can measure iron in liver sample, and that iron is measured in the form of dry weight, and it should be in the range of 300 to 1400 micrograms per gram dry weight of liver. And you can do an assessment of iron present in the liver by an index called as hepatic iron index. This iron index, it should be less than 1. And this liver biopsy is very important because it helps in establishing and excluding liver cirrhosis. It can help in diagnosis, or if there is no liver cirrhosis, and it then can exclude. And this liver biopsy helps in prognosis of a patient. And we can do one more test which helps in identification of liver iron stores is MRI. And after finding out whether any value has increased from upper limit range, then we have to check for hemochromatosis in a patient. Any value greater than this normal value, we have to screen for hemochromatosis. After diagnosis and hemochromatosis patient, you have to treat that patient. How will you treat that patient? You have to remove excess iron, and you have to do supportive treatment of a damaged organ. Okay, for removal of excess iron, what you have to do? You have to do weekly or twice weekly, based upon the severity. You have to do phlebotomy. Weekly or twice weekly phlebotomy. After doing phlebotomy, how much ml of blood you have to remove? You have to remove 500 ml. Remove 500 ml. If you remove 500 ml, how much iron is present in this 500 ml? It will be around 200 to 250 milligrams of iron will be present in this 500 ml of blood. After taking out blood through phlebotomy, which parameters will change? So, if you see plasma transferrin saturation, it remains increased. It remains increased till available iron stores are depleted. Iron stores are depleted. If all iron stores are depleted, then only plasma transferrin saturation will reduce. Otherwise, it will not be decreased. So it is not that much helpful when you do phlebotomy patient. It will remain high only. But which parameter will tell you that iron stores are decreased, and iron is stored in a plasma protein called as serum ferritin. Serum ferritin. This ferritin concentration will fall progressively with each phlebotomy. This serum ferritin will decrease. So this means this will reflect decrease in body iron stores. Body iron stores. Then how many days you have to perform this phlebotomy? Till you have to perform phlebotomy till serum ferritin is less than 50 micrograms per liter. 50 micrograms per liter. And this phlebotomy can take how much time? It can take up to 1 to 2 years time to reach this serum ferritin level. And after reaching this serum ferritin level, you have to maintain this serum ferritin in the range of 50 to 100 micrograms per liter. And after attaining this concentration, if you are maintaining this in this range, then you can do phlebotomy for once for every 3 months. Every 3 months you can do one phlebotomy, and you can maintain this serum ferritin levels in the range of 50 to 100. This is about phlebotomy. You can treat this hemochromatosis with chelating agents. Chelating agents. These chelating agents can be given parenterally and orally. Parenteral and oral. This parenteral drug is called as deferoxamine. Deferoxamine, and this will remove 10 to 20 milligrams iron per day. Iron per day. And the removal is much less than phlebotomy. It will remove 10 to 20 grams iron per day, but it is much less than phlebotomy. This oral chelating drug is deferricerox, but it is not useful in primary hemochromatosis. It is useful only in secondary iron overload, that too in thalassemia and secondary iron load conditions. Okay, secondary iron overload condition, that is parenteral iron therapy in those patients, in sideroblastic anemia patients. In these patients you can prefer oral chelating agent, that is deferresirox, which is helpful. It is not helpful in primary hemochromatosis. And you have to tell, you have to caution a patient about alcohol. Alcohol is strictly prohibited. Strictly prohibited. If you give alcohol, if patient takes alcohol, then what will happen? If he takes alcohol, patient takes alcohol, it increases cirrhosis of liver by tenfold. It increases cirrhosis of liver by tenfold. So you have to caution about alcohol in a taking alcohol in hemochromatosis patient. You have to treat diabetes mellitus, that is supportive therapy, or cardiac failure patient. You have to give insulin in diabetics mellitus patient. You have to treat cardiac failure patient and hepatic patient failure patient through conventional therapy. Conventional therapy. Whichever treatment is done for these patient, you have to do those treatment. And for loss of libido and change in secondary sexual characters are treated by testosterone and gonadotropins. And if patient goes into an end stage liver disease, in those patients you have to do liver transplantation. This liver transplantation will reverse hemochromatosis. Chromatosis. So this is very helpful. Liver transplantation is very helpful, as it will reverse hemochromatosis. Then prognosis. What is the prognosis of this patient? With phlebotomy, what changes you will see in a patient? What changes? If you do phlebotomy, what changes? The liver will decrease in size, and function will improve. Function improves. Then what will happen to the skin? Pigmentation decreases. Pigmentation in skin decreases. Next, what will happen? Cardiac failure may be reversed. Next, they will have little effect on hypogonadism and arthropathy. These cannot be cured completely, so they have little effect. This phlebotomy has little effect in hypogonadism and arthropathy. If cirrhosis is established, that is established cirrhosis patient, it cannot be reversed. It is irreversible. Once cirrhosis has reached established stage, then it is not reversible. The patient will land up into complete liver failure. So patient will have portal hypertension, patient can have hepatocellular carcinoma, and all these things can be seen in a hemochromatosis patient if established cirrhosis is seen. This is about hemochromatosis. In the part 1, I have discussed about biochemical basis and clinical manifestations of hemochromatosis, and in part 2 I have discussed about diagnosis and treatment of liver hemochromatosis patient. Okay, thank you.